Most of my practice now involves ankle sports medicine, injuries to the ankle, to ligaments and tendons. Most of the work that I'm doing involves ligament tears, usually ATFL, CFL tears, lateral ankle instability, peroneal tendon repairs, syndesmotic instability. Every patient should be treated like an athlete. They have lives, they have people that depend on them, they have occupations that require them to be back at work in a timely manner. Some of the patients I've had who have really appreciated internal brace are patients who are construction workers, firefighters, police officers, people who work normal day jobs which requires them standing for 8-9 hours. Initially, what I was doing with most of my Broströms was just a simple modified Broström, just using simple sutures to repair the ATFL. The problem with that kind of approach was the patient was being put non-weight bearing for a few weeks, then weight bearing is tolerated in a cam worker boot, and then progressing to physical therapy. And now with the advent of internal brace, I've been able to push my patients much more after the surgery. We've been able to get patients to be weight bearing as tolerated immediately in a posterior splint, get them into range of motion exercises 1 week after the surgery, get them into a cam walker boot 1 week after the surgery, and get them into physical therapy 10 days after the procedure, which has been great for patient satisfaction. So when I first started doing internal brace, I was very hesitant. The hesitation was there, look, there's more dissection involved, we're putting some more implants in the patient, but there were some patients who complained of chronic ankle instability. These patients, I just didn't feel just by putting some sutures on would give them the support that they need at the lateral ankle. And that's when I looked at the picture of the internal brace, it made complete sense. You're putting an anchor in the fibula and one in the talus, and you're reconstructing and basically putting a seat belt on the lateral ankle, which would later lead to improved stability for the patient. The Broström repair is very critical to me because you must repair the ATFL along with stabilizing the lateral ankle. The use of the fiber tack suture tape, you don't have to be concerned about the real estate along with the internal brace. It's a small incision, it's a small hole, and you can implant it nicely and securely into the fibula and leave enough space for the internal brace to be anchored. Over the past several years, I've focused more on not only just addressing the lateral ankle instability, but also addressing the syndesmotic instability. The combination of internal brace and Tightrope XP has been of tremendous benefit to my patients who have suffered from instability, both at the syndesmotic level and at the lateral ankle. Having done over 400 of internal braces, I think adding internal brace to your armamentarium is very useful. Patients have early range of motion, patients have early weight bearing, and that really speaks volumes about your practice. And this procedure is able to help them get back to their normal routine much faster than just a typical simple Broström.